Hello, everybody. Thank you so much for coming today. We don't have too many announcements, just that we're still deciding on a company to go with the sweatshirts because we've decided to do sweatshirts instead of t-shirts this semester. And next week, our meeting will be with Abby Golding, who will speak about living with brocas aphasia. So that will also be virtual, and more details will be sent on that in the coming week. And yeah, that's all the news that I have for now. And I would like to introduce Professor Gangi-Gaertner about her experience just having a Q&A session about being a previous medical SLP.
So, hi everybody, you can call me Roseanne. You can ask me questions throughout, and I have some great questions that were sent to the chat as well. I am 5 years into my career as an SLP. I started out in linguistics many years ago here at Queens College, taught in linguistics, did some graduate work in linguistics, and felt like I was missing something. And I spent some time with both of my parents being hospitalized for different reasons. My father had a stroke, my mother had cancer. And I really fell in love with being in that medical setting. I feel like I was taking prerequisites at that time to become an SLP, and really seeing the connection between the speech classes, the psych classes, and being in that setting, being able to look at an MRI and understand the connection between a tumor and the difference in language got me really interested in the whole field. Now, I was on the fence until really the end of graduate school, because I also loved working with teenagers. I loved working in a school setting. I liked working with middle school kids on writing and on language, but I was really drawn to working with adults because I saw how much you can improve somebody's quality of life at a time when they're suffering. And a little bit different from working with kids, although there are medical SLPs working with children. We'll talk about that as well. I know for me, with adults, you're working with individuals who had the ability to speak, who had the ability to eat and lost it. So something that they never had to think about before and was just kind of done unconsciously became something they had to do with effort if they could do it at all. So trying to restore the individual quality of life, returning people to independence where possible, or at least increasing their ability to interact with their family and kind of sit down and have a normal meal, was all really what got me engaged in staying with adults after I left graduate school. So my experiences in grad school let me work with kids and adults, and let me work in both a medical setting. I was in an inpatient rehab, which was in a hospital that worked primarily with people with brain injuries or stroke. And my other internship was in a middle school. So very different from each other. And I got to compare the two. You'll hear a lot of people say, well, I just want to work in the school so I can have my summers off. But I know people who worked in the schools and went back and came and actually worked with us as temps, as per diems in the summer, because they didn't want to lose that experience that they had with adults. So they got the best of both worlds in that sense. In the hospitals, you can get great benefits, but at the same time, you're only seeing people for a short amount of time. Often you'll see people for maybe anywhere from a few days to a few weeks before they move on to other settings, either to go home or to go into a long-term rehab or subacute rehab, as we call it. You might know them as nursing homes, skilled nursing facilities, but essentially that's where people will go to recover after a prolonged illness or a sudden, like an incident such as a stroke, recovering after chemotherapy. And others are there for the long term because they can no longer care for themselves. So we get to see the mix of people who are getting ready to go home and getting better, and those we're just trying to keep from getting worse. We're trying to help people maintain their ability, including cognition. So I don't know if you all realize that we do work on, we can work on working memory, on attention, on not just speech and language, but overall and general cognition. So think about the population most affected are individuals with dementia. And I've worked with individuals with Alzheimer's. I've worked with individuals with Lewy body dementia, and tried to work with them to some extent to help to reduce the effect the disease is having on their abilities, Parkinson's as well. I work with a lot of Parkinson's clients and trying to keep their abilities strong and not declining along with the course of the disease as much as is possible. But, there's some cases where it's just really a matter of just trying to find some stimulation or training a caregiver to communicate a little bit better with a loved one who has primary progressive aphasia. Now, did you all see the Wendy Williams news last week? Who's diagnosed with primary progressive aphasia and frontotemporal dementia, which is a very difficult disorder because it can change your personality. It starts young. So we can't always change the individual's experience, but we'll do our best to help them communicate, sometimes through symbol systems, sometimes through AAC, so augmentative communication. I've helped people get devices to try to help to some extent. And at times it's just really training the caregivers to help facilitate communication and swallowing. Now, I keep mentioning swallowing, and that's a really big part of my job as medical SLP. It's about half of my caseload. And strokes affect swallowing, Parkinson's affects swallowing, any physical disorder. So if you have cancer of the tongue, or if you have radiation that affects your larynx, you're going to have an effect on the swallow. So I love getting people to eat again when they haven't eaten for a long time. It's so exciting to be the first person to give them a bite of food and to help them to facilitate strengthening their abilities again. Getting people to be able to communicate. Like I had one gentleman who he is 5 years after a stroke and he hadn't said his whole name out loud for the longest time, but I worked with him for one session. And at the end, he was saying his whole name on demand. And his family was like, we hadn't heard him say his name. He said, I love you to his wife, which she hadn't heard. So there's that acute work in the hospital when you're getting people right after they become sick. There's that longer term rehabilitation in a place like a nursing home or skilled nursing facility. And then there's home care and outpatient, which is really what I'm doing now. I started out in the inpatient rehab. I did my clinical fellowship in a skilled nursing facility, but now I go to people's homes. And sometimes it's right after they've come home from rehab. Sometimes it's years after their stroke. And really trying to help get these abilities back. And it's very gratifying. It's, eating and speaking, it's and thinking, think about how primary that is to the human experience. And I know those of you who are interested in working with kids are also thinking about this, about helping kids to communicate, to advocate for themselves. Pediatric medical SLPs work with feeding with kids too. We work with people who might have extreme medical compromise and finding ways to bring them pleasure, like to help them level up closer to where they were before the illness or incident that changed their lives. So kind of that's the trajectory. The pros, like I said, is that it's really that satisfaction. The pay rate is about the same, I find, as the school. Sometimes it's a little less, sometimes it's more. There are some people who charge an arm and a leg for independent sessions, self-pay. But often, and a lot of my clients are on Medicare. So we take insurance for their as their payment. And Medicare pays less and less from year to year. But I have found myself being able to be comfortable, even though it's not, this is not a wealthy profession, but I've been able to pay my bills and be very happy with what I'm doing. So the pros are largely, they're emotional. They are very much, it's so satisfying to help somebody feel better. And I think it's like what brings nurses to the profession. All nurses do get paid more, but to me, a nurse's job is so much harder. I don't know that I would be able to run an IV or to administer care in the same way the nurses do. So they deserve every dollar they get and more. For me, I was able to combine my interest in healthcare with my love of language. So that linguistics background comes into play. And it's it's like the happy marriage between them. And I think about language, I think about speech, I think about everything from what we do in phonetics to what we do in syntax, and all these things come up with different adults in different cases. But I also get to think deeply about the brain and how the brain works and what specific effects occur relevant to certain types of injury and disease. So it's solving a puzzle, and I think that's true for any SLP. It's a lot about problem solving. It's about taking this basic knowledge, meeting somebody new, reading their reports. And for me, it's reading medical charts, finding out what medications they're taking and seeing if any of them might be affecting swallowing or speech. Learning about that to me is really interesting. Learning to read a chart and learning that what the signs of an infection might be with an increased white blood count, and saying, okay, we're probably going to see somebody who has altered mental status and maybe some changes in cognition. They might not seem like themselves because of the infection. So I've learned you pick up more and more over time, and being immersed in those environments, you learn so much more about your own health. You become an advocate for it as well. And and it's important that we continue to advocate for our clients. We think about cultural concerns. We think about how certain people are dismissed based on how they sound, making sure that we don't, I had a client once who was a Korean gentleman who had had a stroke 5 years prior. I understood every word he said. And the person who assessed him said he was only 60% intelligible, but it was because she couldn't understand his accent. So, I'm an advocate for finding fairness in the field and making sure that people are better informed and not just, basing their judgments on their own. We don't base our judgments on ignorance. We base it on sound practice. So all of that comes into play every single day in what I do, and I love it. I love being in it. I love teaching about it. And so so I think I talked a little bit about the different environments. I will say that at the hospital, it was a lot of fun, but for me, I like developing longer relationships. I like being able to see clients for longer periods of time. At the hospital, you kind of get a short blip and they move on to rehab or they go home. So you can do this kind of healthcare SLP work, this medical SLP work, and develop the long-term relationships and see progress over time in a home setting. And I love that about this home outpatient piece. You can get it in an outpatient clinic as well. We see it in the university clinics too. People come to us for a long time because recovery takes a long time. Sometimes I'll have a voice client and we'll teach them strategies and be done in 6 weeks. Or I'll have a stroke patient who just wants to keep coming back for years, making gradual progress because there is still plasticity and there's still ability, but it's slow and steady. I get to see both of those individuals and try to make their lives better. Let's see. How do you find you interact with other medical professionals in your setting? Interdisciplinary approaches. Oh my goodness, so much. And whether you're in the hospital, the nursing home, and even in home care, you are interacting with the individual's physicians. So even in home care, I'll be calling the doctors to get prescriptions, to get referrals, but also to get information about the client. In the nursing home, it was speech, occupational therapy, physical therapy, dietitians, the kitchen staff, the nurses, and the MDs and nurse practitioners, all working together on a client's case. At the inpatient rehab, we had weekly meetings where we would sit and talk about, each client would come up each week and we'd all contribute information and share it so they'd know where we were at our stages in therapy, and trying to give recommendations to other professionals of how to help them interact. And they would come with me with questions. And I, in turn, would get information, say from the OT, about how should I be making sure this person is sitting? I need somebody sitting up when they're eating. So can so getting advice on how to make sure that we were working on positioning together. OT also works on manual feeding. So kind of that marriage between OT and speech, we were able to work on making sure that if people were self-feeding, that they're eating safe textures, that they were capable of, even capable of lifting the spoon to mouth. And OTs are some of the most creative people in the healthcare field. The adaptations, spoons that are elongated or extended, bowls that are curved on one side so you can scoop up against it, different types of pillows, different types of like cushions and wheelchairs. if you need a creative solution, talk to an OT. Working with nutritionists to know, and being able to read a medical chart to know if I had a client who's diabetic, I wasn't going to be giving them test meals that were heavy on carbs and sugar. I was going to be watching their diet and their needs, watching for allergies, watching for, say, dialysis patients who needed a certain protein level to be given, so we were constantly interacting on making sure, I would make sure that they were able to handle the textures they were given, that they were able to chew and swallow them safely. The nutritionists made sure that we had the right nutritional balance, and the OTs made sure that if they weren't able to feed themselves, that we had somebody feeding them. So that's just like one example of like so many different interactions, even creating boards. So somebody who was on a trach but still had their language fully was able to point to different information to be able to get help. And then eventually to help them to be able to speak by changing the way the airflow came through their mouths instead of through the trach, so that way they'd be able to speak out. You'll probably learn about speaking vowels. I don't know if Professor Ball talked about them in anatomy, but if somebody has a trach, if they can't breathe through their vocal cords, there's a whole place below the vocal folds and a tube implanted there. So the air flows directly into the trachea down to the lungs. Sometimes the air has to be forced that a ventilators use. So there's a machine that will actually take the breath for you, and kind of change the pressure so you're taking the breath. And others that are just, sometimes you're just delivering oxygen, extra oxygen there. So the level of complexity is relative to the level of need. But I had people who were on those ventilators where the machines were doing the breathing for them, and I got them to be able to speak and be heard. And I got them to be able to eat even small meals for pleasure, because even if you're receiving food through a G tube, which is directly into your stomach, or a J tube directly into your intestines, you still feel mouth hunger. And I can't tell you how many people in the nursing home who could not eat by mouth were watching cooking shows. They're torturing themselves because they could think all the thing about was food. So we tried to make sure they at least had that satisfaction. We tried to make sure they were practicing and trying to get to the point where they could swallow again if there was an issue that was preventing that. We weren't always able to accomplish that, and that's one of the saddest parts of it. I'd say I see the question is, what was my favorite part of being a medical SLP is really just, even in dire situations, trying to bring some light into the person's life, try to give them some hope, and try to help to facilitate change for them. And the hardest part is knowing that we've kind of hit a point where, we're not going to make any more progress, where a person is declining. And, but I sat and held the hands of somebody with like a really late stage dementia and tried to communicate with them. And sometimes even just sitting there with them peacefully was enough, which is why I spent too many hours when I was at the nursing home seeing people who weren't my clients in addition to my clients, and like clocking out and running back in to visit people, which I wasn't supposed to do. But I was, you develop relationships with people, and especially in that long-term care setting, you want to see them thrive. Even if they're not making progress, you find ways to help. Working with, recreation, another team member, it's like working with recreation to help stimulate clients who had dementia, to help with them if they were having difficulty with behaviors. Like we had people who'd wander into people's rooms and try to escape and get out the elevator, and it was often because or screaming out because they were scared. So it's trying to help solve those puzzles of like what was going wrong, and working with the nurses and the nursing assistants, who, again, another frontline worker that, oh my goodness, you can't believe how hard it is and how much hands-on personal work they do. That's one of the challenges. There's not always enough staff to go around. So we try to work together to make their lives easier, and by making their lives easier, we make the patients' lives better. So a lot of problem solving, thinking on your feet, and working with the team to make that work. Let's see. Difference between SLP and an audiologist. So while SLPs can screen hearing, and we're taught to screen hearing, and we take audiology classes to learn about hearing, we don't get to prescribe hearing devices, and we don't have the ability to do the detailed testing that an audiologist does. I will often refer folks to audiologists, and I do a lot of referrals. I'll send people to otolaryngologists, also known as the ENT, to check their vocal folds to make sure they're safe to do voice studies with. I'll send them to neurologists if they're showing signs of difficulty that really can only be explained by a change in the brain. But I'll send to audiologists when they're hearing issues to make sure that we get a really robust evaluation of their hearing ability and possibly fitting for hearing devices. Now, on the medical side with younger kids, we have SLPs working with kids after they've had cochlear implants. So we kind of work hand in hand with the audiologist there. The surgeons will put in the cochlear implant, the audiologist will make sure that the devices are tuned up, and the SLPs will help to facilitate language in that case. So it's another, not just swallowing, but another pediatric case where you really could be working with kids, fresh out of surgery and working to rehabilitate language. But hearing is so critical to communication. There are even studies that loss of hearing is related to reduction in cognition. So I encourage everyone to get their hearing tests regularly. I got mine done recently and it's very good. As it is an SLP, we can screen it. And we want to rule out if there's a hearing problem, if we see a speech issue, and this is for children and adults. But if we've ruled out the hearing issue and there's still difficulties with speech and language, then we have to address those underlying issues. But the audiologist should always be part of the team, even if we're just doing the screening, but absolutely refer to good audiologists. And not everybody can afford it. Insurance covers some hearing aids and not others. Some really good ones can be like $3,000 for hearing aids. It's so much money. And the over-the-counter ones aren't always tailored to the individual. So somebody will pay, it's still not a cheap amount to get something over the counter, try to use them, and they're not going to deal with their hearing issues. My mother is an example. She has no hearing in one ear. So if you remember from your audiology classes, if those of you have taken them, they have those bi-cross systems where you can deliver sound from the non-hearing side to the hearing side. That's what she has. If she just went and bought hearing aids to amplify both ears over the counter, it would not have worked because it wouldn't have picked up anything from her left side. So refer. If it's not in your scope of practice, you refer out. And you learn so much from these other professionals that you know what to look for. And you develop your list of contacts and connections to make sure that people are getting well cared for. Like I have ENTs in my pocket who don't give me they give me no kickbacks, but I know they're good. And they take Medicare, so that's probably like the low point of medical SLP is what insurances people have. Can they get the services they need? I had one guy on a one of those Medicare Advantage plans. They advertise everywhere to elderly people, but it really cuts your services significantly from standard Medicare. They were only able to get 15 visits. This man had a really complex stroke and he was starting to make progress. We could not get any more visits. So I gave him and his family as much information as I could. If he lived closer, I probably would have stopped in for free, but he was far enough away in Westchester that I couldn't just justify popping in. But I'm hoping they were able to get them into a trial with NYU sending some different devices. That's another thing is the technology. I'll get to that in a moment. But that's the saddest thing is when you can't continue to treat because of insurance. And so advocating for better pay through better insurance, making sure that your companies will take everything is a challenge. I have one client that I'm seeing pro bono because he's relatively young and his insurance was not meant for long-term speech care. So I'm able to see him because he's close by and I can pop in and see him once a week for free. I can't do that often because otherwise I would not be able to feed myself, my children, and my cats and pay tuition for 2 kids. But I do it when I can. And I really love being able to get in there and make a difference. Technology. So we get to play with the devices. I had an individual with ALS who was losing his ability to speak because his muscle, the progressive disease changed the ability to use his muscles and started off really with difficulty with the outer extremities. But then even to facial expression, swallowing speech, I was able to get a device that he can control with his eyes. So he's able to look at different icons on the screen, dwell on them, and it would say what he was looking at. And we programmed it and customized it to him. At first, he was able to still press it because he still had some control of his arms. Over time, less and less so. And he unfortunately passed away. It was a rapid course. He went from being able to walk 1.5 miles to not being able to walk at all within just a few months. So that's the sad thing too, is that rapid progress. And somebody asked me, it's like, do you just become like calloused? And you don't. You feel it all. But if feeling it makes you want to do it, help people more. And I think but you start to accept. You start to know what certain diseases look like. You know what the trajectory of disease looks like and what the expectations are. And you just give what you can and try to help when you can within the course of the disease, knowing that you are going to lose people. And it's sad, but it's it's part of the normal cycle of life. And I want to help people at all stages of life. So that's what really pushes me toward the adults, especially because there aren't that many. Like we have the company I work for part-time outside of Queens College, we have one speech therapist for Queens. We have a ton for Nassau and Suffolk. A couple other companies are opening up, but there aren't that many speech therapists willing to do home care in Queens because it doesn't pay as much as being in a hospital or being in a nursing home. But it leaves a lot of flexibility. Like I was able to make my own schedule so I could teach 4 classes or 3 classes and do clinical work. And I still see clients 2 days a week. And I love it. So it gave me a great deal of flexibility, and I'd make my own schedule, which has really been helpful to me. So I see people like once every hour and a half from like 11 o'clock through 5 o'clock, pretty much twice a week. And I get paid by the session. I used to get insurance from that company too. They were able to get me on a part-time basis. So there are some places where you can do 20 hours, 20 sessions a week and still get insurance. So if you're thinking of starting a family, or if you have like multiple environments you want to be working in, that's also a nice thing about this side of being an SLP. And I have some private clients that pay me directly, but I try to keep the rates reasonable. So, people who don't have insurance to cover it. What else? How difficult is it to get into the medical side of speech pathology? I think it comes down to what internships you have. So I found that I learned everything I needed to know in grad school. And the truth is, ASHA's regulations make it so that anyone who goes through a graduate program needs to have the basics. You have but most importantly, you have the critical thinking and the problem solving skills. But you get your class in dysphagia, you'll get your classes in adult language and cognition. We have anatomy, you take your anatomy classes, that's all going to come back into play. But getting into that externship at the inpatient rehab really was what kind of set me on the path to staying with medical. And I did still apply to a couple of schools because, I was like, I kind of miss the kids sometimes too. But I really liked working with little kids, just could not get up and down off the floor. That's one thing. Being in medical SLP with adults, I don't play on the floor with them as much as that was fun. It's just too embarrassing when I'm trying to get up. If you really like being on the floor with kids, go into early intervention. But some people find it more difficult just because there aren't that many externships out there and not as many clinical fellowships, but that's changed in the last few years. The clinical fellowship year after you graduate, it was often difficult because hospitals weren't hiring CFs, but now they are. And sometimes they'll just be a 1-year program and not continue, and then you'll have to find another job after. But it's like a year of the best boot camp you can have. And I have friends who've done it at LIJ, who've been at North Shore, who've had Mount Sinai, so different clinical experiences in the hospital. And a lot of nursing homes will hire clinical fellows. And sometimes the supervision isn't great. My supervisor left after 3 months because the other clinical fellow was giving her a hard time. They both left in September, and I wound up having a part-timer watching over me. But I'd had relationships within the facility. I had that full interdisciplinary experience. So even though my mentor left, I ended up with another mentor, and that was fine. And I continued seeing my patients, and I rode right into COVID in my first year. So I got my license the paper came on March 23rd of 2020. So I was an official licensed SLP with my Cs, and suddenly everything was shutting down. But I still had to go to work every day, except when I had COVID myself, which I was out of work for about a month. We wore PPE from head to toe. That was the scariest part of being the medical side of it. But I felt like we were doing something important, even though we weren't always treating clients in a normal way. Sometimes we were just helping the aides pass trays and making sure that people got a visitor, or walking into rooms, working with recreation to help people FaceTime their families that they couldn't see from inside. So while it was devastating, it was also, I felt like we in the profession worked really hard to shine. And even like the SLPs at Elmhurst Hospital, because they were really well versed with the inside of the nose, we're giving COVID tests in those tents on the street over on Broadway. I mean, we really were involved in it. Now, another technology piece is that if you like the idea of doing things like scoping, you can learn how to pass a camera through somebody's nose and watch them swallow. And this is something that is within the scope of practice of an SLP if you have the competency. But we're training in, and that's called fees. We're also trained to work with radiologists. It's another interprofessional piece, to take modified barium swallows where people will eat things or drink things that have the substance barium in them, which you can see on an X-ray. And you watch the X-ray, you watch where the food is going. Is it going down the esophagus as it should? Is it going down the trachea? Is the tongue pumping? Is something not moving right? It's another way, another part of our diagnostic toolkit, but something that SLPs, especially on the acute level in hospitals, are really engaged in. I've just thrown a lot of stuff at you guys, info dumped like the last bit. Ask me more questions. Tell me if you want me to clarify anything. What do you want to know?
I'm kind of curious. I literally just realized that you became an SLP of 4 years ago. I thought it was longer. I thought, like, can I ask what you were doing beforehand?
Well, I started out in linguistics. I
Yeah.
graduated from Queens College in '97 with a bachelor's in linguistics. I went to the CUNY Graduate Center for a few years working on the doctorate. I hit a stopping point, partly because I took a class in neurolinguistics and I'm like, I should be working on stuff with the brain. But I feel like I'd hit the wrong spot. I was actually in the same class with Professor Ijalba and Professor Yael Newman. And they went on, because they were already SLPs in the program, and they went on to get their doctorates. And I took some time off, had kids. I kept working as an adjunct here. I was teaching future teachers the grammar of English and syntax, who were planning on teaching English to individuals who speak other languages, and kind of kept my toe in the water. And I met somebody, and I was volunteering at my daughter's school. I was volunteering in their library, and the SLP came in and was working with kids. And I was interested, and I was listening and saying, okay, this reminds me of working in syntax, the problem solving she was doing. I'm like, this is really interesting, but oh my God, I have to go back and take biology and chemistry and all these prerequisites, or physics. I can never do it. And I was on this parent leadership team with somebody who was an SLP. And I told her, I was in linguistics. I did this. I didn't know. I was thinking about becoming a librarian. I didn't know what I was doing. She said, why aren't you going into speech? I said, I can't. It's too hard. I'd never be able to do that. I said, Roseanne. And she sat me down and she explained everything she did. And it was so exciting. And the problem solving and all of the pieces started falling together. So I talked to Professor Pratt here on the other side of the department. I said, what do you think? She's like, apply the program now. So I came and I did 2 years. I did a second BA. I did all of my prerequisites, and I finally finished the psych major I started in the '90s. Took some cognitive neuroscience classes that I was really interested in, and knew I was in the right place from like when we started doing those, watching the videos and observing, like, oh my God, I want to do that. This is the right thing. This is what I want to do. And I applied to graduate schools, but my parents are both having health problems at that time. I applied to 2 schools, and thankfully I got into them, and I was able to attend the school of my choice, which was the closest to home, which was Queens. So I've been a Queens college student. I graduated from Queens 3 times already. And Queens wasn't even my first school. I started at NYU. I had a year and a half. I dropped out and became a secretary. I was in marketing in the early '90s. So this was a long and circuitous path. It's not a typical path. I've had friends in the medical field who came through a much typical fashion. They went right from their undergraduate to graduate and ended up in hospitals, ended up in nursing homes. But yeah, I'm still a baby as an SLP, but I've been teaching here since 1998.
Eric, I had no idea that you have so much like foundation for this.
You know, and it's really what drew me to it was that language in the brain. And if I had known this years ago, I probably would have fallen right into this program. But um, I did go to some NISHLA talks back when I was in linguistics. My friend brought me to a talk on stuttering, and I was so fascinated. And I was learning a little bit about aphasia, and then I got to neurolinguistics and I learned a lot about aphasia. I'm like, I really want to be treating people, but I felt like I couldn't start over at that time. But who knew that I could? I finished in my 40s, and it's possible. I tell everyone, you know, if you don't find your right path the first time, you will find it eventually. You know, as long as you can make a living and be happy in the middle, doesn't really matter what you're doing. But to have found something that really I truly enjoy and being able to do that half the week and teach half the week, I get like both of my loves totally fulfilled.
I,
I, oh, sorry. Do you want to go, Carol?
I already asked my question.
Okay. So do you find that the increasingly lower pay for Medicare and other insurance companies has led to a shortage of speech pathologists and services?
I think that's a big part of it. You know, it's unfortunate because we lose a lot of really good practitioners to the schools because of that stability, because of the, you know, especially if you're in New York City, you're treated like a teacher, you're in the union, you have the same retirement. So we do lose people. It's something that I really want to fight to advocate for, especially on the state level, trying to see about our both Medicare and Medicaid reimbursements, additional insurance reimbursements, but also trying to create services for individuals that are grant-based. So, for example, the Parkinson's Voice Project that Professor Vaccaro has brought the grant to Queens College, we can treat people for free with Parkinson's based on this grant. So, you know, that's, if I'm able to set up an establishment like that, a nonprofit work, so they can make enough to live and still give people care, that's my ideal circumstance. I would love to see that kind of service for every type of chronic condition that requires speech. But it's challenging, but you find your ways to cobble things together, and it's not so low pay. Like, you also don't accept things like, nobody takes minimum wage. And I see people in other states who get like 30 an hour for part-time, like, no. Going rate is usually about 60 an hour, which, you know, figure that's an hour of time. And then if you're, you know, of patient time, and if you're moving between patients, it may be a little bit less, but if you have a lot of energy, I know people who can see 8 clients in a day and do really well. And they get, you know, and that $60 is the reimbursement. Some people charge 100 for the session. Some people charge 125 for the session. You don't have to charge that much and still make a livelihood. So it's doable, but there's advocacy that has to happen politically. Part of it is writing to Congress and letting them know that speech needs to be held up in as much, with as much, that's what I'm looking for, and given as much respect as PT and OT. One of the problems with reimbursement was based on a missing comma. So essentially we have 2 caps in Medicare, one for OT, one that covers PT and speech. It was supposed to be 3 caps for OT, comma, PT, comma, and speech. But instead they lumped together PT and speech. So clients can only get certain numbers of sessions in a year. However, if you can show that you're providing skilled services and you can show that the client is making progress, you can continue to see people even beyond those caps. You have to justify, you have to write great documentation, but I've been able to get people to continue to get the treatment they need, even after hitting those caps. So we find our workarounds. We advocate for our patients, we advocate for ourselves at the same time.
I wanted to ask about record keeping for patients. I know some other settings have SOAP notes, but how do you do it for the medical setting?
It depends upon the insurance. So if you're on Medicare Part A in a nursing home, for example, so that's like the 100 days after you've been discharged in the hospital, you write a big evaluation and you do a progress note after every, roughly after every 10 visits. Medicare Part B, which is kind of the outpatient form, we have to write the equivalent of a SOAP note every day. Mine all go into an electronic chart. So it pre-populates with a lot of the information, client information is all there. It shows me the note from the previous time. So I can, change it to reflect the exercises I've done, to show what the results were and if there's any progress made, or if I've adapted anything or did any certain cueing to be able to keep up with it. But I take too long because I tend to like over obsess. But you really should only take about 15 minutes to write those notes. It's not that bad, maximum 15 minutes. And I know some people write a lot less. My PT friends would be like, made progress, period, check, 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 did these exercises, done. The speechies are all like, we're writing like journals for each of them, which we don't have to do. But to me, it also helps if I have to pass a client on to someone else. And I've worked in environments when I did my externship at the inpatient rehab, that we'd be passing clients around very frequently. So we would have our really detailed notes, including what exercises we did, so they could pick up the next day. It's the one thing I didn't like about that is I didn't always have continuity of care in that setting. Whereas, now it's like my patients are mine. But daily notes, in the hospital, there are also electronic record systems. You'll put in your evaluations, you'll put in your, like a note of for your visit. But it tends to be relatively brief, and just as informative as possible without reinventing the wheel. Everyone complains about paperwork though. It's like, I have to write my documents. I love treating, then I got to write about it. But your administrators are like, the most important thing is the writing, because we don't get paid if you don't write this. So they put so much pressure on your billing and your writing. And I try to learn to write in such a way that it's started to flow more automatically, the type of like we call skilled language. So really representing what I do, because if I don't do that, then I can't get my clients their care. So I know how important it is, as much as it's my least favorite part of the job. But I think it's the favorite part of every job is the paperwork. It's not impossible though. It's not hard. Iman, what are you thinking?
I just had like a question about, is there a way to kind of gear towards becoming an SLP in like a hospital setting, or it's like all the same process?
There are some schools that might have like there's some schools that are based at hospitals that might have a more direct relationship. But really any school that you attend, like I have 4 of us from my class at Queens, which isn't always known as a very medical program, are medical SLPs. That was like 25% of the class. We got everything we need to know. We got our voice classes, we got our swallowing classes, we got our adult cognition classes, our aphasia classes. And this is all part of the core requirements of ASHA, that a program has to do this to be accredited. So you can really do that anywhere. And then I would recommend, if you have contacts in the field, it's sometimes hard depending on patient privacy. You might be able to shadow an SLP beforehand on the medical side, but really try to get those internships during your graduate program. You have to make at least one solid medical internship. And that's what changed everything for me. I learned so much in that 4 months. And that combined, it synthesized everything I learned in dysphagia, everything else I learned in adult cog was like right there. It really all came together. So, and they're also, I think speechpathology.com is free for students. Since you can't earn continuing education credit, you can actually look at some of the intro programming or attend ASHA or attend NISHLA. And there are classes that on the medical side where you can learn more and take that experience and knowledge with you. So every time, even before I graduated from my undergrad, my second BA, I was attending these talks and getting to know more about that side of the field so I can talk about it on interviews. But they're not expecting you to know everything when you get there. They're expecting you to know what you learned in your dysphagia class. And they'll ask you some gotcha questions like, how'd you do a bedside swallow exam? But these are things you'll know. These are things you'll know in any program, anywhere. Hey, Carol, what are you thinking?
Something else I would like to add, if you're able to have the chance, I did volunteering at a hospital, at Elmhurst Hospital. And so if you want a hands-on approach, that's also really nice to be able to have that experience. I was able to feed patients directly and get a feeding certification. So just volunteering. So maybe an internship might be a little bit harder, but volunteering, hospitals are usually always open to it.
Hospital and nursing homes too, especially now that the pandemic has died down. They're looking for people, even in recreation. you can get to know the types of clients that you would be meeting and help in a different way and feel if the environment's right for you. It's a good way to feel it out. But yeah, in graduate school, you have to have 450 hours of direct client treatment to be able to finish graduate school. And about half of those hours for me were in a medical setting. About half of them were in a school/clinic setting at Queens. And even at Queens, I had clients, I had aphasia clients, I had clients with dysarthria. So I had exposure in graduate, like I said, even in a program that wasn't considered so-called medical program, gave me enough experience that I could jump into the field comfortably. Any other questions?
Thank you.
Oh, you're very welcome. Go ahead, Chloe.
I was gonna ask, do you have any experience in the NICU speech pathology setting? Because I've been hearing a lot about it, like videos and stuff, and I find it really interesting, but I heard that it's fairly hard to get into.
I haven't had the experience myself, but it's so important because you're doing early feeding. It's so, even like trying to figure out for babies who don't have that suck reflex yet, trying to move them from being tube fed to maybe starting to take drops of milk with a tube attached to the finger, or starting to facilitate that early feeding. But I haven't had that experience because I'm terrified, to be honest. Because they're so small and they're so fragile, and I'm very big and bull in a china shop. So there are pediatric tracks that do address the NICU. There are certifications that you can do after graduating for specific experience, but it's often kind of getting into that hospital setting. I would look into a place like St. Mary's and, working with, in a medical population and then trying to move into the NICU. So like go from medical peds to infant. But there are classes, there are master classes at ASHA. There are online classes like through MedBridge or through speechpathology.com where you can learn about any setting and any subset. So you'll be maybe a class on what to expect in the NICU for beginners. So learning a little bit about kind of what it's like when babies come out at that gestational stage, how developed or underdeveloped their lungs are, what the feeding need is, and how we participate in those settings. But yeah, there aren't as many, I don't think there are as many positions, but because remember, it would just be feeding, and many NICU babies are still being tube fed, or they're developing a suck right away and they don't need the feeding help. So it really depends upon the need. You might be an SLP in a hospital and call to the NICU if you're a ped specialist. But if I can find somebody, I'll try to bring them out because I think you'd love to hear from them too. We'll see if my friend Lauren has time because she's the one who's starting her pediatric practice, but I think she's busy up to here. So I'll try to make some connections there. But yeah, it's challenging, but there's definitely work for us to do. And even work in infancy, like working with babies after they've had surgery to repair cleft palates, to restore eating, working with infants and toddlers, say with cerebral palsy, because you're starting to work on facilitating the kind of, everything from like there, you're working with OT and PT as well. You're working to facilitate sitting, so you can facilitate the kind of breathing to support speech. And there are lots of ways to get involved with very, very young children from a medical side perspective as well.
Thank you.
You're welcome. Any other questions, anyone? Well, thank you for listening to my rambling on about this setting that I'm so passionate about. If any other questions come up, feel free, Carol, you can share my email address with and I'll put it in the chat here too. But unfortunately, because I'm working in home care, I really have a hard time bringing anyone to shadow me. It's often the question I hear the most is, can I come with you? But as much as I would love to, I don't have that capacity. But if I hear of other opportunities arising, I will try to make that connection and, and pass that on to the group.
Yes, and then of course I can share it as well. And just overall, thank you so much. It was really inspiring and it was really informative. And just, I know it was like a good conversation.
Thank you so much. Thank you so much. Thank you all for your great questions, for participating. And like I said, I'm here if you ever need anything. All right.
Thank
Have a lovely